All right, everybody, welcome to week 14. This evening, we're going to cover evaluation and management. And before the evening is over, we are going to do some examples of the questions for E&M, and they are going to be comparable to the ones you will be tested on. This is coming from the AAPC's data bank. So evaluation and management, everyone should have their CPT books available. Evaluation and management actually starts on page 1. But what I want to do before we dive into the manual is just give you an overview of that particular chapter, some of the main sections, some of the things that we need to look for, and then we'll go into our CPT and make some notes, some tips on how to code for that section, things to look for, and then we will put some practice exercises into play, right? So we're going to define E&M, which stands for evaluation and managing the patient, evaluation and management. We are going to cover the difference between a new and established patient. Identify the location. I should have actually had that bolded and highlighted in red. That's so important in reference to E&M services. Make sure you know where you are, where the services are being rendered. The main thing for me with E&M to help you get started is making sure you have coded to the right location and type. And when I say type, we'll get into the definitions of those terms. Understand that the requirements for the different levels of service. There's going to be levels of service, right? 1 through 5 or 1 through 3. And then how to properly level. That's going to maybe be the most important bullet point in tonight's presentation is how to properly level an E&M service. And then we'll wrap it up towards the end of this presentation with a actual provider's note and how we abstract from the provider's documentation to arrive at our level of service. Also, remember, I do have the chat box over to the right of your screen. So if you have any questions as I'm going through, or if you need me to repeat or clarify anything that I'm going to cover, that you can just jot that question right into that chat box. Okay, so again, like I said, the E&M section starts on page 1, and to the left of that is some graphs, some charts to help you with leveling. We'll discuss that a little briefly, maybe during the boot camp, because I want to show you how to use this section, this part of the E&M section manually, and what we're looking for. That's where I want to place our concentration this evening. So E&M, they say numerically it should fall last because it begins with 9-9, and we just wrapped up with medicine last week, and that also began the 9 category. But because of its frequent use, because every specialty uses evaluation and management codes, they're placed in the front of the CPT manual. Okay, so they're placed in front of the CPT for frequent use. So just remember that E&M codes are placed in the front. Now, also remember there's E&M type codes in the medicine section also. When we talk about having yearly physicals or ophthalmology services, those are not going to be found in the front section of your evaluation and management. It is going to be found in the medicine. So although these are evaluating the patients, that's why these particular procedures are here. The other ones are more of like eye consultations and yearly physicals. Those are what you're going to find in the medicine section. Okay. So again, the definition of E&M is what they're doing is evaluating and managing the patient, right? So hence the acronym E&M. And so during that time, they're going to inspect and observe palpitations, listen to your breathing, that little instrument where they hit you on the knee, they're testing your responses. and your physical status when they are performing an E&M type service. So here are 6 steps, and we will develop our own little methodology on how to code these. But these are 6 steps that are going to help you um, determine or help you guide you to the correct evaluation and management code. So you can see here, I just want to talk about it for a minute. I'm on page 1 in the 2016 CPT Professional, page 1, and I'm just looking at the red highlighting and the green highlighting on my page because I'm just looking at the categories and subcategories, right? And there's also guidelines. We're going to spend a lot of time on the guidelines. The guidelines are located starting from page 3. Is it 3? Not 3. 4. Starting from page 4 all the way to page 10. We'll be putting some notes in that section, and that's going to help you how to code E&M services. So you're going to select the category. And when I say category, not the first set of E&M that you see up top in black, because that's basically telling you how to code E&M services, but where it starts on the second E&M towards the bottom of the page, right? So there you can see, remember I said one of the main things you're going to have to focus on is the location. So you always have to remember where you are. So in the green, right, you have the green, which are your categories, and then you have some subcategories, right? So you have hospital observation, you have office visits, you have hospital inpatient. Turn the page to page 2. You have consultations. And then let's stop at consultations for a second. So now that we know it's a consultation, patients coming in for a consultation, they want to know where the consultation is being held, right? Is it office or other outpatient consultation? So it tells you there. Or if it's an inpatient consultation, it tells you what page to go to. So again, you need to know where the patient is. And to me, if I'm just looking at these pages right now, the green are your locations, right? This is where the service is being rendered for the patient in the green areas. And then the red are like your subcategories, which is going to provide additional information about that location. So that's going to be one of the main things we're going to do is select the category or subcategory of service. Then we're going to review the level of E&M descriptors. And then we'll determine the history, the exam, and the medical decision making, which is step 3, 4, and 5. Step 3, 4, and 5, a long time ago, they used to ask this question on the exam. These are the 3 key components of E&M. The 3 main things you need to know to level your service correctly. The level of the history, the level of the exam, and the level of the medical decision making, right? And then once you have the level of all 3, then you can select the appropriate level of service. So, for example, the locations, you can almost, by the time we do a little practicing and a few drills, you'll almost be able to just go straight to your location by either finding it on the page or by memorization, especially with your office visits. What you're not going to be able to arrive at quickly is going to be how to select the appropriate level. And that's where I want to focus and spend time this evening, right? We're going to spend a lot of time on determining the level of the history, the exam, and the medical decision making. And the history, exam, and medical decision making are what's going to be described or discussed on pages 6 through 10. Right? Pages 6 through 10. And I'm going to actually have you go through the book and write which pages the history comes from and which pages the exam comes from and which pages the medical decision comes from and what you need to look for on those particular pages, you'll have documentation and little notes, little reminder tips there. Okay. And then with the compilation of all of that information, we'll be able to have enough data to select the correct or the appropriate level of service. Right. So these are different categories. So again, I know you've looked at some of the reference pages. I said page 1 through 3. Those are all your reference pages, right? These are the locations and the various entities where evaluation and management services can be rendered. On my screen right now, I am looking at office visits, right? So if I was to ask you what page I would go to, let's open up our CPT. I'm looking at page 1. And I was going to just ask you what page I would go to in reference to office visits. You look at page 1. Remember, we're looking at the E&M towards the bottom of the page, and you'll see office or other outpatient services 99201 through 99215. It tells you go to page 11. Okay, but now that you know that it's an office visit, you have to ask yourself, okay, the patient that's coming in to the office, is this patient new or established? This is information you're going to pull from your question because there's no more surgeries, right? We're done with surgeries. As a matter of fact, this should be the easier part for you because we're not talking about anatomy and physiology at this point. We're talking about where the patient goes to be evaluated or treated. That's what we're talking about with evaluation and management. So again, you would look at and read your scenario to see if that patient is new or established. So if the patient was new, right, office patient, and they were new, what page would you go to? You're going to go to page 11, right? Or if they were established, where are you going to go? Page 12. See, so remember that these reference pages that I like to call them, they really do help you and cut some of the time out. But remember, you also can go to evaluation and management in the index. But I think this is a much more guided and illustrated and detailed way to let you know how to get to the pages quickly. Okay, so on the left, you'll see the first 4. Look at the first 4 numbers in the CPT code on each side, right? So you have 992. So you know that office visits are going to, most of the E&M codes, a lot of them start 992. But with an office visit, if they're a new patient, that 4th digit is going to be a 0. And if they're an established patient, that 4th digit is going to be a 1. The only thing you don't know is what the level of service is, which equates to that 5th digit there in the CPT code, right? So office visit, you can see, just look on your page 1 on your reference page and look for office, the location. And then the next thing you would ask yourself, because of the subcategory, the red I'm going to call the subcategory, you're going to ask, is this patient new or established? So it's giving you, it's asking you other questions actually if you're looking at the location. All right, so it's giving you an example here of what the actual CPT code looks like for E&M. So right now I am on page 11. Page 11. I'm looking at page 11 and I'm looking at CPT code 99201, right? So 99201, remember I was speaking briefly about the 3 key components that we're going to focus on. Those are what you see in the black bolded areas. So you can see for a 99201, the patient has is a problem focused history, exam, and straightforward decision making. And it's the same thing that's mimicked on the slide. Those are in red because those are the 3 key components. So in order to bill a new patient level 1, the patient's history has to be problem focused as well as the exam. And then the medical decision making needs to be straightforward. And until we discuss those so that you know what's entailed in those, they may not make a lot of sense to you, but these are called the 3 key components. And towards the bottom, sometimes if more than half of the time is spent face-to-face counseling the patient, then you can actually code that E&M service based on time. So at the bottom here, it tells you it's typically 10 minutes. And even in your CPT description on page 11, it also states the same thing, typically 10 minutes. So sometimes that's good to kind of highlight in your book so the time jumps out at you. Because I know if you're just looking at this page for the first time, you had no idea that it gave you the amount of time in the CPT. So make sure you have that highlighted. Okay. Now we were talking about a new versus established patient. New versus established patient. And so just so you understand what determines a patient from being new versus established, if you're looking at this slide, you can see what I have in red, the last 3 years. 3 years is the key number here. Okay, so a new patient has not received any face-to-face professional services from the physician, qualified healthcare professional, or a physician, qualified healthcare professional of the exact same specialty, subspecialty within the group practice within the last 3 years, right? So established, they have received service within the last 3 years. So let me give you a little scenario. So where are we? 2016. So if let's say I started going to the provider in 2012, 12, 13, 14, 15, 16. So that would be 4 years, right? So if I've been going to this doctor my whole life, but I moved away to another state and then came back. So remember 2000, what did I say, 2012? And I came back in 2016 and, I'm like, oh, I need to go see the doctor, my family doctor that I've been going to all these years. Because the time span, although that has been my established doctor all of these years, because that time span went over 3 years, I am now new to that practice again. And I've seen a lot of providers, patients have been gone for years and they're still billing them as if they were established and that time frame has passed. So remember, please remember. Now, also, I want to explain that you could be seeing a doctor, right? And that doctor's gone on vacation and now someone else is coming or taking his place. If that provider is the same specialty as the one that's so lucky enough to be on vacation, then that patient's still going to be established to that provider because the provider belongs to the practice, right? However, if the provider is of a different specialty, like it could be a gastroenterologist instead of an internal medicine provider, then that patient is new to that provider. Okay, so just remember here, as it states on that first bullet point, a new patient has not received any face-to-face professional services from the physician. So that means new, they've never seen them before, right? Or in the last 3 years. And so they haven't seen a healthcare professional or a physician or a qualified healthcare professional of the exact same specialty or subspecialty within the practice within the last 3 years. So I think we got it. The difference between new and established. Key number, 3 years. Okay. So office or other outpatient services, that's what we're talking about on page 11. Okay, so office or other outpatient services. So if we're saying an office visit, just for you to know to use 99201 through '05 for new patients, 99211 through '15 for established patients. The place of service needs to be either an office, other outpatient clinic, or ambulatory facility, like an ASC, right? That's place of service 24. Remember, your place of service codes are on the front, the first page in your CPT book. Place of service codes. You need to make sure you remember where those are. And then again, depending on the location, then whether the patient is new or established for your office visits. Okay. Observations is another type of service. And so observations, remember, we just spoke about office visits, just going to the doctor, or ambulatory setting. Ambulatory meaning you can walk in and walk out that same day, right? Ambulatory, you're not spending the night there. But then we talk about observation services on page 13. Now, let me just summarize observation for you, okay? So observation, they're not spending the night, they're being observed, right? So it's less than 24 hours. However, a couple of years ago, they did establish subsequent observation care. But if it is subsequent, it will say subsequently in your question. So it's not like you're going to have to figure that out. But there's two different types of observation, right? There's two different types of observation. There's observation when you are in and out the same day, right? So you come in, or there's observation where you're in one day, out the other. I know I said less than 24 hours, but if you're placed into observation at 10 p.m., yeah, you're going to have one date. And when you're discharged, you're like at 8 a.m., it's still less than 24 hours, but you have two different dates, right? So guess what's going to be important when you're coding for observation? You need to make sure you highlight the dates, right? And maybe even the times of when the patient comes in. And you'll know it's observation because they will tell you they're in observation stat. It will have the term observation in the question. So again, observation is a location in the facility for them to evaluate, right, and manage the patient. All right. So there's hospital observations in and out the same day. So on page 14 in your CPT, look, there's two codes on there, right? There's 99217 and then there's 99218. Okay. This particular page is when they come in one day and then they leave on a different day. Okay. So your 99218 is when they come in, when they're coming in. And your 99217 is when they're being discharged or when they leave. Numerically, you would think 7, then 8, but it's flipped, reversed in this particular scenario here. So they have 99217 is when they're being discharged, and 99218 is when they're coming in on different days. So at the top of your page or somewhere, you might want to just write different days so you just don't get confused, right? Now, when they are in and out on the same day, it tells you that first paragraph on page 14, we're underneath observation care discharge services. That last sentence, there, it says, including a hospital admission and discharge of the patient on the same date, highlight that, same date, C codes 99234 through 99236. So that's when they're in and out on the same date. I just want you to get comfortable with that. On page 15 are just your subsequent observation. Okay, so remember, we're always looking for the location when we're reading our question. And as you'll notice on each of the pages, what is bolded are those key components in each of these CPT codes. So let me get through this so we can get into the good stuff. On page 16, so with observation, as I stated, there's in and out on the same day, and there's also subsequent observation. Again, the time is going to be very important. I have a scenario here before we move on in reference to observation. This is in reference to observation discharge services. So again, the time. Once I know this question is in reference to observation, I want to see a date. I want to highlight the date, and I want to see if there's any times in my question. I need to highlight it. Okay, so let's look at this. 9 p.m., patient goes to the emergency room department with a concussion and is evaluated. 10 o'clock, they put him in observation. So remember, now it's 10 o'clock. the night before, right? They are in observation for 12 hours, right? So we clearly know that there's going to be 2 dates, right? So we're looking at how long they've been in, what time they went in, right? 10 a.m. the following day, they're discharged from observation status. So again, if they're in one day, out the next day, they're going to need 2 separate dates, right, for observation, admission, and discharge. And it says report the observation care discharge code for services provided on this discharge date. We already said that if you turn back to page 14, that your discharge code was going to be 99217, right? And if you have to see what they're asking you for. They only wanted you to report the observation care discharge. If they said, when did they come in, then you'd say 99218. But they left with a 99217. Okay? So again, the key thing for observation, make sure you look for the time and the dates, if any are available. All right. So, and again, in red on this particular slide, same scenario. If they are admitted and discharged on the same date, you look at 99234 through 99236. Okay, 99234 through 99236 is where they are in and out on the same day, and that's page 18. That would be page 18. Okay. On page 17, because the presentations they flip back and forth because those are kind of grouped together. I don't know why they're not grouped together in the CPT. But on page 16, on page 16 is our hospital services when a patient is being admitted into the facility, right? So when they're being admitted, and it will say patient was admitted to the hospital, or you will see the term admission, so you know that's inpatient, right? So they're being admitted into the hospital. Then you would go to page 16, and it has 3 levels for the admission, 99221 through 223. Okay, so when they're there, let's say they were admitted, and now let's say you were admitted on Monday and you're there Tuesday, Wednesday, Thursday, you could be discharged on Friday. Well, Tuesday, Wednesday, and Thursday are considered to be subsequent hospital care. That's found on page 17. Subsequent hospital care. That means the patient's already there. It's after admission, right? It's like day 2, day 3, right? That's called subsequent hospital care. Okay? And then again, subsequent hospital care also has levels from 1 through 3, as you can see there. We just need to know what those key components are. Turn to page 18. Turn to page 18. So on page 18, this is where you found the in and out on the same day for your observation. In and out on the same day for your observation services, and also your hospital discharge services. Okay, so we spoke about the hospital subsequent codes. That's like if they're there, they were admitted on Monday and they're there Tuesday, Wednesday, Thursday, that's going to come from subsequent hospital care. Okay. All right. So when they're talking about admit and discharged on the same day, we're looking at page 18 here. So this is the other scenario. So patient admitted. Remember again, you're looking at the time because you would highlight the time. Patient is admitted at 2 a.m. Feeling better by 8. That's only 6 hours, right? So they're in and out the same day. Okay. So you would have to select your code from 99234 through 99236. And the only way you'd be able to select your code again is once you know the levels of those 3 key components. Okay. And then hospital discharge services, which is also on page 18. Those are going to be based on time. So that's why I have how long there. If it's 30 minutes or less, then you're going to use CPT code 99238. If it takes longer than 30 minutes, then it's 99239 for hospital discharge. So for hospital discharge, it's based on time. So next to hospital discharge, you better write how long, question mark, and how long. All right. And then please notice that last bullet point where it says discharge of a newborn, because I'd maybe even just write it. It's in the book, but I'd write it maybe on my discharge page just in case that question comes up. 99463. And make sure you would have to read and see what's included in that. 99463 or where they're being discharged from in order to use that code. Okay, consultations. Consultations begin on page 19. I have the 3 R's up there as a reminder. I'll talk about that in a second. But consultations, the 3 R's are very important. Consultations are from provider to provider, not from patient to provider. What do I mean? So if I go to a provider and I say, hey, doc, and he's telling me, hey, Geneve, I think you may have a breast mass. And I'm like, no, I don't want to hear that. I want to go see another provider. I want to have a consultation with another doctor. If I choose to go to another doctor by myself, it's not going to be considered a consultation. I'm just going to be a new patient to that doctor. But if my doctor says, okay, let me send you to a consulting physician, he has to send over a request. That's one of your first R's, and we'll talk about that on the next slide. He sends over a request to the other provider. That provider then sees me, evaluates me, and then responds in writing back to my original provider. And then, he has to send a reply. So he has to do a request, respond, and then reply. Okay. Render. Okay. So I'm sorry, I'm just flipped this slide by accident. He has to render the service. So he's going to see you, the other provider, the consulting provider is going to receive the request from your original provider. He's going to render the service, that evaluation of that breast mass, and then he's going to reply to my original provider with in writing what his findings were and what his suggestions are. That's considered a consultation. So be careful of the scenario where they try to give you consult codes as an option, but the patient decided themselves to go see the patient. I'm sorry, to go see the provider, because then it's if the patient decides themselves, they're a new patient. But if a doctor requests, that's going to be the key word in that question, and then you start to look for those other R's, the other provider rendering service and then replying back to the doctor, then it's considered a consultation. Okay, so remember the 3 R's. And consultations are divided by where the service is being rendered. It could be provided in an office or other outpatient settings. That code range is 99241 through 45, or it can be inpatient, meaning in the facility, right? 99251 through 99255, okay, as far as consultations. And again, just a reminder on the 3 R's, there must be a request by another provider. So on page 19, right? So I hope you're writing these 3 R's on page 19, right? Your request by another provider. That consulting provider needs to render. That means he needs to render opinion after evaluating the patient. And then he needs to respond with a written report back to the requesting provider. And it's important that they have that on file, because consultations, of course, are going to reimburse a lot higher than a new patient, right? And so they have to have the written documentation to support. So if they get audited for billing a 99241 or whatever the consult code is, they can say, well, yes, we did the consult, and here is the documentation to support it, right? So they do have to have the written report from the other provider in the patient's file. So remember the 3 R's for consultations. And again, if the patient wants to request a consult for a second opinion, it's not so. They say to code with an office visit, right? The new patient. And after the consult, there's only one consult, right? So if you had a consult with a provider, when you go back to him, it's not another consult. He can't bill another consult code. He's then going to bill the established office visit code when you go back. Um, Important modifier in this section, modifier 32, that's when it's mandated. Like if workers' comp tells you to go get a physical or something like that, or to go, it could be paternity testing, right? That is court mandated. It's going to be modifier 32 when it's requested by like the insurance company or court order. Modifier 32. So consult code, of course, there's no newer established because consults, they're all coming for the first time. Right? And again, let me just reiterate that inpatient consult codes, you're only going to use once, one consult per admission. Okay, and then after, like I stated, after that consult, then you would just use the subsequent visits when you're inpatient, the subsequent visit codes if he comes back to see that patient again. Now, Medicare has done away with consult codes. They will not, because this is a billing type thing, so they're not going to ask you questions about that on the exam because that's really more of a billing type issue. But they do away with consults. So people are like, well, how can you distinguish a Medicare patient who has received a consultation? Well, when they did away with the consult code, they came up with a modifier, and that modifier is AI, which is listed at the bottom, last bullet point. And AI goes on to the admitting physicians, because look what's going to happen now. Let's say a provider admitted me into the facility. The CPT code is going, I'm just going to say admission, a low admission 99221. Right? But I'm having stomach pains. Well, maybe it would have been higher than that if I'm going to get a consult, but I may have been having stomach pains. When he bills his 99221, he's going to append modifier AI to let the insurance company know. And this is how I remember it. I'm like, AI am the chief person in charge of this patient, right? So because if he calls in a gastroenterologist to come see me, to consult with me, that provider now is still going to have to use 99221 because they no longer use consult codes. So unfortunately, it will affect the reimbursement, right? Because they don't really have it set up to understand when you're using a regular code, one code for 2 different meanings. That's not how it's set up. That's just how it goes. So that's how Medicare bills their consultations. They will use they'll use new patient codes for those patients or new admissions. Emergency department. So the emergency department, I am on page 22, does not distinguish between new and established, right? Because you just go there. And in order for a facility to be titled or labeled an emergency room, they must be attached to a hospital. So sometimes I see a lot of urgent care, they want to receive the same reimbursement as emergency rooms, but they are not set up or qualified the same way. They're not attached to the facility and they're not open 24 hours. They have actual office hours. So that's, to me, is more like provider. They may have extended hours, but it's not 24 hours, right? So they cannot bill the same as the emergency room. Okay. Critical care services is going to be important. As you can see, it's a lot of verbiage to read on 23 and 24, but let me just kind of summarize this for you. I want you to look on page 25. So on page 25, there's a chart there, right? It says total duration of critical care codes. And it will say that the patient is in critical condition or has a life threatening. You will know that you will need to use critical. It will tell you how much time. This is another one that's dependent on time, okay, that is spent rendering services to the critically ill patient, right? So if you look at this little grid, I just kind of highlighted, put little squiggles around it, because this is how you calculate your time. You don't have to do much. They already have it all calculated for you in this chart. Less than 30 minutes, they're like, if it's less than 30 minutes, don't even try to build critical care code, right? So it's important that you're looking to see how long, right? Because they could go into the emergency room department and get services rendered to them, which could be a 99284 or 85. That's the emergency room department code. But then patient could go into cardiac arrest and they have to administer some type of critical care. Now that's going to be, and they spent maybe an hour or 40 minutes administering critical care. That would give me 99291, right? So I'd maybe have 99285, modifier 25 to say it's a separate situation, and then my 99291 because of the time that was spent administering critical care. So just remember page 25, and we'll have a few examples to go through. So we will revisit this again. Let's just look at some of the a description of critical care, though, so you can understand the definition of critical care. Because on this slide, it says that it acutely impairs one or more vital organs systems such that there is a high probability of imminent or life-threatening deterioration in the patient's condition. Okay? So it tells you on page 24 everything that's included in your 99291. That's what it tells you on page 24. But what you're really looking for is that patient got critical care, and now you're like, okay, how long was it? How long did it take? Okay, so you may just want to write impairs more than one vital organs. And it seems like a lot, but when we do the questions, it's going to be a lot easier. And so there's critical care. Here's the kicker. So critical care, like I said, as an example, you can have critical care and it can be administered in the emergency room, right? Critical care can also be administered in intensive care, right? ICU. If you're looking at the slide number 23, slide 23, you'll also see that they have critical care codes for pediatric and neonatal patients, which are the kids, right? The kids and the babies. Let me see where their codes are really quick. Because while I'm looking for that, I want you to know there are going to be, if the critical care, I'm talking about children right now, if the critical care is rendered in ICU, intensive care, right, then you're going to use the pediatric and the neonatal critical care codes based on the child's age, right? You'll know which one to use. Right? You're going to use that. And please note that usually the critical care codes for the pediatric and neonatal for the children, they're bundled. They have a whole bunch of services bundled into that one CPT code. And those services are listed in on the page. I just don't want to get distracted doing both at the same time. But if critical care for the children or the neonate is administered in the emergency room department, then you are going to use the adult critical care codes, which is 99291. Remember that on page 25, dependent on time. Okay, and I don't want to get too deep into it now. I'm pretty sure we have a question we're going to go over when we do that part of the review. So, and then I'll be able to explain it. But just remember, everything's all wrapped up into the kids' codes when they're having their services rendered in ICU. But if the kids end up having to have critical care in the emergency room, they're going to have to use the adult critical care codes. Just remember that. And also, when it's administered in the emergency room, whether it's adult or children, with those critical care codes, if other services are provided, they can be billed. You just have to make sure they're not rolled into the critical care code. But I'll tell you things like CPR, which is 92950, endotracheal intubation, CPT code 31500, and I think it's, I can't remember, I think it's 31500 or something like that, a line placement, when they're placing a line, that also can be billed along with critical care. But until we see a question, it will make more sense to you when we are able to go through the scenarios. They're just talking about the critical care services. Again, they're based on time, right? So make sure you're paying attention. And remember, if it's less than 30 minutes, you can't use the critical care code, because sometimes they like to say, oh, and they spent 20 minutes doing critical care services. I'm like, well, you just wanted to throw that in there because I can't capture that, right? So it needs to be over 30 minutes in order for you to capture it. And it also tells you here that it doesn't need to be continuous time. Okay. And part of it, reviewing records, tests, and time with family members. So if he's away, off the floor, you can't include that. I'm not going to lunch and trying to include it in critical care time. All right. Well, again, less than 30 minutes, you're not going to report it. First 30 to 74 minutes, you might as well just look at that chart on page 25, but it's 99291. And then each additional 30 minutes is 99292. And they're going to refer you to that table, which I just stated, on page 25. Okay, one. Okay. And then here we have nursing facility services, which starts on, these are for like long-term care facilities, page 25. You can see that on page 26 too, the initial nursing care facilities. And the nursing facility, you can see they have their own discharge codes. So again, you got to remember the location of where the services are being rendered on page 27. Remember, once they come in, now they're going to have subsequent days, right? And then they're going to have their discharge services, which are on page 27. Okay. You got rest homes or custodial care, that's on page 28. Those are divided into whether the patient is new or established. But as you can see, each of these codes, as we've gone through the pages, they all have those key components, right? Most of your questions, remember, on the exam, you're only going to have 10 questions in E&M. And because we're outpatient providers and we're going to do a lot of services with or code for physicians, you have to kind of think about that. So that's where most of your questions are going to come from, like your office visits, your hospital, maybe a couple consultations. And then by the time you ask 2 or 3 of each of those, you're at 10. So there's no way they're going to be able to, touch on each of these sections here. So the ones up front that I just covered are going to be maybe what they're going to question you on. And that's what I like to provide homework to you on too, so you can make sure you're understanding. On page 32, they talk about prolonged services. Prolonged services. Okay, I'm on page 32. Okay, so prolonged services, you can have with and without direct patient contact. And that is something that goes over your regular office visit. They may say, I spent an additional hour. Let's see how long it is. Less than 30 minutes. They have 30 to 74. So they could say I spent an hour counseling the patient about her diabetes, right? That could be considered a prolonged service. And you would use CPT 99394, I'm sorry, 99354 or 55, the time, dependent on the time. Okay. It's kind of like not really like critical care, but it's an additional service. So it's another service that's time based. And usually, how will you know to pick it up? Because they'll say the provider spent an additional X amount of minutes, and then you're just looking for that, counseling the patient about her condition. Okay. And as you can see, it's an add on code. So you can tell it can't be used alone. And it gives you those codes there. These are the other add-ons, the 99358. See, which is on page 33. Those are prolonged evaluation and management. Okay. And the 99354 is more of like a psychotherapy type service. So make sure you highlight psychotherapy. And the 99, see, these are both add-on codes. And the 99358 and 59 are like after direct patient care. But they don't have to have patient contact. Standby services is also time-based. And standby services, for example, mom's getting ready to deliver, she's high risk, she's 54, having twins, right? And so providers like, hey, may need assistance here because mom's high risk, so there's another provider. The other provider has to be in the facility, right? And he has to be on request of the other provider, so he cannot bill standby services at home. He actually has to be in the facility if he's needed when it's time for mom to deliver. And it's only reported if he's on standby for longer than 30 minutes. Okay. And then they have little services here in reference to case management. Okay. Someone could be their drugs or whatever they're prescribed and they're on. Okay. Case management. A medical team conference requires at least 3 providers. And then there's care plan oversight, which is more on hospice and home health agencies and nursing facilities. So that's more kind of like inpatient, right? So you won't see too many questions on that. Okay. And then your preventative medicine services, right? That's on page 37. Your preventative medicine. So it's not like your annuals. Those are your annual physical exams. And it's divided again by whether the patient is new or established. So on page 38 for the established. And then you have your counseling section. Counseling, and it will say counseling. And then your face-to-face services. And those special evaluation and management services that's on page 41, these are like if someone was sent, like if your job sent you, again, this would maybe be one of those pages where you may need to use modifier 32. Okay. Then you have newborn care services, lots of services. I'm on page 42. Okay. So this is newborn, initial hospital birthing center services. So again, this is not maybe something that we're going to see because there you go into inpatient neonatal, so they're not going to test you on the inpatient side, but it's good to know because you want to see what's involved. On page 44 is where we start talking. Actually, this slide here where it says pediatric critical care transport, the provider, in order to bill that, there actually needs to be a doctor in the ambulance. Okay. And it's billed by increment of time. On page 44 was where I was talking about all of the things that are included in the critical care codes for the babies, for the neonates and the pediatric kids. On the right-hand side of page 44, starting with vascular access, halfway down the page, you'll see all of the services that are included, like panels, yeah, that are included in the pediatric critical care codes, which are on page 45. And you can see there, like with page CPT code 99468, these are critical care, right? So all the services that are listed on page 44 are covered. Even 31500 is included in that. So remember, I was like, you can bill that if they had it performed in the ER, but if this is performed in ICU, in an intensive care unit, then you can't bill these particular services separately. They're all rolled up into the CPT codes on page 45. Okay. So again, this is just talking about the critical care. Wait, let me go back so you can see the ages. Okay. This is from age 3 through 5. It includes same procedures of 99291 through 99292. And it says guidelines list additional procedures included in these sets of codes, which is on page 44. All right, so in case you're not aware of the age, right, when I said neonates and pediatrics, so neonates, they say, are what? 28 days or less. Okay. Infants, 29 days through 24 months. And then a young child is age 2 through 5. That's good to know, right? So again, neonates, 28 days or less. Infants, 29 through 24 months. And then a young child from age 2 through 5 years of age. And then they have initial and continuing intensive care services, care management, coordination of care. And then I think the last thing they have is advanced planning, which is on page 51. Right? So again, when you're coding the steps, you're going to read the category. That means I want to know where I am, right? You're going to review the level of E&M services, determine the level of the history, the exam, and the medical decision making. And once you have that, then you're able to select your level of service. All right. Does anyone have any questions before we continue into the leveling portion? Lines are open. Or are we good? Sounds like we're good. We're just ready to get all into it. So I'll keep going. E&M, guys. This is the kicker here. All righty. I actually like it. Okay, so we're going to talk about the leveling now. So get your pens ready because we are going to do some writing. Because after we do our writing, then we're going to do a few examples, right? So right now I'm going back. I am on page 5. That's where I'm going to be. I'm on page 5 in my E&M coding service guidelines. On page 4, you'll see on the top right-hand corner, it gives you the definition, what we spoke about for new and established patients, right? So everything that we discussed is going to be in the guidelines, or that we discussed that's important for you is going to be in the guidelines. As you can see, there's leveling. There's guidelines that we use. Okay, there's 95 versus 97 guidelines. The main difference between the two is that those 97 guidelines are more exam component driven. They have more bullet points that you have to select. So when we are leveling, the things that we have to consider, like I said, the first three are the key ones, right? The three key components: the history, the exam, and the medical decision making. And then if it's based on time, then we can look at counseling, and then we can look at the coordination of care, nature of the presenting problem, then how long, if time is a factor in the code selection. And again, you're going to hear it again, key components: history, exam, medical decision making. The medical decision making actually has the most weight, right? Or they call it it's influential in the level of service, unless we were talking about counseling. Remember, if more than the service is spent counseling the patient, then we can code that encounter based on time. And so your categories and your subcategories describe the number of the key components that are required. All right, so right now I'm just looking at page 5. And here, the first thing that jumps out at me is we're starting a story here when I'm talking about evaluation and management. And the chief complaint is basically, why did the provider walk into the room to see me? Okay, why did the provider walk into the room to see the patient? And so it sets the tone of how complex the visit is going to be. You know, the complexity of the visit for the medical decision making based on what I say when he walks into the room, right? So that's talking about the chief complaint. So right now I'm on page 6. On the top of page 6, actually on the top of page 6 and 7, because the history, remember, we have to understand the key components: the history, the exam, and the medical decision making. Well, the history has about 2 parts to it, maybe 3 parts, right? So on top of page 6, I want you to write history, because this is where your history is coming from. And on the top of page 7, I want you to write history, because that's where your history is coming from, right? On the top of page 9, that's where you're going to get your exam components. So on the top of page 9, I put exam. And then on the top of page 10, that's where you're going to get your information for your medical decision making. Right? Now, I'm going to tell you, rarely are you going to have to go through this detailed process that I'm about to cover. You will when you're coding charts, but for test taking purposes, most of the work is going to be done for you. Right? So when I say most of the work is going to be done for you, you're not going to have to calculate all the bullet points to know what the levels are for each of them. They will tell you a problem focused history, a problem focus, expanded problem focus exam. They'll do things like that. They'll say it so you'll know where to go. But the whole purpose of this is me introducing it to you and telling you how it's actually performed. Right? So that's what we're looking at. So back on page 6. Okay, so the first step, I call it the first step, is the history of present illness, right? So you see that on page 6, right? History, well, actually, that's the second step. History of present illness. So the first thing for the history, remember I said there's a couple of parts. You need to find your HPI. That's your history of present illness, HPI. Sometimes they'll just call it. How many elements of the HPI? And you need to know what's involved in the HPI. If you're looking on page 6, starting about the second sentence in that paragraph, okay, it will tell you the history of present illness is basically asking the patient about the current condition. You see where it's location. It's like, where does it hurt? Duration is how long is it lasting? Quality is like, how does it feel? Is it stabbing? Is it like a stabbing feeling? Does it feel sharp? Severity is like on a pain scale of 1 to 10, how bad does it hurt, right? Um, Timing, when does it occur? Does it happen in the day? Is it happening in the afternoon? Is it happening at night? The context. Oh, when I move my arm, it hurts, right? Modifying factors. But when I take an aspirin, I start to feel better, right? Associated signs and symptoms. Well, since my back hurts, then I'm starting to have neck pain. Okay, so those are things that providers ask when they are assessing the history of present illness, which is called the HPI. Right? So what you can do on page 6 is highlight those things. It starts on that paragraph, that second paragraph, that second sentence there, and you can highlight them: location, quality, severity, timing, context, modifying factors, and associated signs and symptoms significantly related to the presenting problem. Okay, so those are how many things? 1, 2, 3, 4, 5, 6, 7, 8. So there's 8 components of the HPI. Right? 8 components of the HPI. Okay. Now, if I had to ask you what the level of the HPI is, if I picked 1 to 3 of these components of the HPI, if I just said location, duration, and quality, it's considered a brief HPI, right? So 1 to 3 is considered brief. Okay. An extended HPI is 4 or more of these bullet points. So when we start to go through the scenario and it's time for us to pick up the elements of the HPI, you're now counting, right? You see each of these have a bullet point next to them. So I actually wrote mine out to the side of the paragraph, although they are listed in the paragraph. I like to be able to count them, right? So I just wrote them out, just like the way they are on the screen, right? So they're in your book. You can do that on the side, and there's 8 of them. Right. So remember, if it's a brief HPI, it's only 1 to 3 of those elements. Or if it's extended, there's going to be 4 or more. Right? So 4 or more is going to be extended. 1 to 3 is brief. Right? That's in reference to the history of present illness, which is this slide here. Now we have to review some systems. Review of systems is what's on here next. Right? So remember, the first thing here was your HPI, and then you had brief was 1 to 3, and extended was 4 or more. So you can put 4 plus, right? Extended, EXT equals 4 plus, HPI brief equals 1 to 3. Okay. Now you have review of systems. So these are your body systems, right? And basically what it's doing is just doing an inventory of your body. I'm on page 7 now. So this is step 2, right? Step 2 of the history. Step 1 was I needed my HPI. And if I wanted to just recap that, I know my HPI is either going to be brief or what? Or extended, right? And brief equals how many of those little bullet points? 1 to 3. And extended, how many? 4 or more, right? Now I'm moving on to part B, or step 2. You got to get a flow going, right? So second part now is my review of systems. Remember, there's a couple components to the history. Now we're on the second part of it, the review of systems. And basically, it's an inventory of the body. Okay, and that's when the provider starts to ask like a series of questions, checking to see if any signs or symptoms that the patient may be experiencing. He's trying to, gather all of his data. Right. So here, there's a review of systems. Now you see each of these bullet points here that are in black represent body systems that are under the review of systems, right? On page 7. On page 7, the review of systems. on page 7. So you'll see it starts with constitutional, and then it goes all the way down to allergic, right? Okay. And at the bottom, it tells you the review of systems helps to define the problem, clarify the differential diagnoses, because it's going to be talking about what's going on in each of those body systems, identify the need if we need to have any tests done, or serves as baseline data on other systems that might be affected by the possible management option. So you can see all of the body systems here. Now, in that little section on page 7, just like we did our brief and our extended for HPI, here's what I want you to write for the review of systems, right? Problem pertinent. Problem pertinent. And you guys are like, what's problem pertinent? Let me write it out. I'm writing in the chat box to everybody. So problem pertinent, that means they're talking about one body system, right? Problem pertinent is one body system. Extended, an extended review of systems means that they're going to evaluate 2 to 9 body systems, right? And then a complete review of systems. A complete review of systems is going to be 10 plus, right? So 10 or more. Okay, got that? I wrote that in the chat box. Pertinent equals one body system. So if we just said eyes, that's problem pertinent, right? But if I say eyes, cardiorespiratory, gastro, genital urinary, then we're extended. If I say all of them, that's complete, right? So remember, on the review of systems, it's either going to be pertinent, extended, or complete. Right? And sometimes they'll say all other systems negative. That's considered complete also. All other systems negative. And you would be able to count your body areas. And pay attention to this. If you're looking at that third bullet point, you'll notice that ears, nose, mouth, and throat are together. So make sure you see that. But the eyes are by themselves, right? ENT, ear, nose, and throat, and mouth, they're considered one system. You see they're grouped together. Just remember that, because sometimes they'll say I evaluated the ears and then the mouth, and then you're starting to count 1, 2. But notice that they are all together, right? So that's your review of systems. Okay, so they're just doing a little example here. Okay? And they're saying that a single element cannot count towards the HPI and the review of systems. Remember, we were talking about on the HPI, maybe if we talked about my knee's hurting, right? Knee is going to be your location, right? My knee is hurting, the location. And then if I come over to the review of systems and I'm like, oh, your knee's hurting, that's musculoskeletal. Well, they're saying you can't do that. They're saying it's either you're going to pick one or the other, right? So for the example that they have here, a single element cannot count towards the HPI and the review of systems for the same patient. The knee pain counted for location, right, in your HPI. Is it making sense? HPI, we're using all these new acronyms. I think you're getting a little comfortable, right? The knee pain is part of the HPI. And it says knee pain with limited range of motion and swelling documented in the HPI can count as both the location for HPI and musculoskeletal for review of systems. Okay. So that's the example there. Okay. The last part of your history, right, is called the PFSH, and that stands for past family social history. Okay. That's also on page 7. So what's your first part of the history? That's going to be getting your HPI. right? That's your first step. What's your second part of the history? We got to look for my review of systems, right? What's the last part of my history? I got to get my PFSH, right? So at the top, you're not going to remember, right? So on the top of page 6, there's not a lot of space here, but on top where it says counseling, you maybe want to put your steps for the history, right? First, or just one, you could put HPI. Second, you need your ROS, which stands for review of systems. And then my last thing for my history that I'm going to need is going to come from my past family social history. And we're going to talk about that right now. Right. So past family social history. So these are questions still. Remember that the provider is asking the patient, right? Past family social history. Okay. So past family social history, they're asking questions, right? So if you look at the bottom of page 7, you'll see with the past family and so the past history is at the bottom. And then I don't know why it's just all over the place, but the past history is at the bottom of page 7, right? You see the history there. And then this family history is back on page 6. Do you see that? I want to know how you guys are going to code this so you know they're grouped together. That's where your family history is. And then your social history is back on page 7. But they all go together, right? They all get grouped together. And you see that each of them have bullet points. It may be good to highlight them all the same color, the family, the past, and the social, so you know they're all grouped together when you're looking for that section. But here's how that works. Okay, so there's 3 sections, right? There's past, family, and then there's social history. Okay, so remember I gave you the little numbers. Problem pertinent is 1 for like your review of systems. Well, on the PFSH, on the past family social history, brief is considered 1 out of these 3 sections. So if I ask one question from your past history, it's considered brief, right? Brief. Right, it's here. Just wanted to see if I could get a better element for you. Okay, so brief. Do you see that third column, right, where it says past family and or social history? Do you see that? They have it there. So I'm sorry, if they pick one of these systems, if they just take it from the past history, it's considered pertinent. I kept saying brief. It's considered pertinent. So pertinent equals 1. Okay, and then complete is if they ask from another area, like if they ask something about the family, he answered, or they ask something about his social history, then and he answered, then that's considered complete. So that's 2 to 3. Okay, so let's go over that again. For the past family social history, which is your PFSH, and I'm just going to talk about this whole thing here in a second. If I just ask from one of these sections, just one. So if I just say, look at your past history bullet points. If I just say, have you had any prior hospitalizations? That counts as a pertinent PFSH, right? If I said, have you had any prior hospitalizations and were you in the military? And the patient answers, or if they ask them about alcohol or drug abuse, that's also part of your social history. Then I've asked from the past and I've asked for the social. So now that makes it complete. Get it? Yeah. So you just got to find a way to know that your family history, your past history, and the social history, they're actually all grouped together, right? And if someone just asks one bullet point or one, like they could ask 2 questions. They could say, I'm looking at past history right now. They could say prior hospitalizations and current medications, but that's still under past history. So it still only counts as 1. I think I just set a light bulb off on someone. Yeah. So it still counts as 1, right? But if they ask from something from the family, then now it becomes complete. Or if they ask something from the social, and you get it. One area is pertinent, 2 to 3 is considered complete. So here we have again, and some people like the little graphs, but I just like to write in my book, right? So remember the HPI. Remember we said brief was 1 to 3 and extended was 4 or more. You already have that written in your book for the HPI. That's the first step of your history. Your review of systems, right? Review of systems. Problem pertinent, 1 body system, right? We got that written down. Extended is 2 to 9. We got that written down. And complete is 10 or more. Got it, right? Past family social history. We know they're scattered on the page. It's okay because we know what we need to do, right? So past family social history, if they're just asking from one section, or if it's just one, then it's considered pertinent. Or if they're asking from 2 or more areas, then it's considered complete. Okay. Look at this. It gives you, this is a calculator, a grid calculator, to help you understand the level of the history based on what we just spoke about, right? And we're going to have examples of that. So don't worry, I know you're ready for it. So here's the example. Okay. What does this patient have? Their chief complaint, patient came in with a cough, right? Now look, this is so much fun. It's better than surgical coding, I think. Now, come on back over on page 6. It's taking a little longer, but that's because I'm explaining it to you and you're taking it in. The HPI, we already said to our HPI, how many little bullet points is there? There's 8, right? Now let's see what's going on with the HPI. So this is actually, we're chopping up encounter, a progress note, right? So this is, patient comes in with a cough. HPI stands for history of present illness. So this 2-year-old patient presents with a, what type of cough? A barking cough. What does a barking tell you? Barking is going to tell you how it feels, right? So that could be quality, right? Occurring at night. Oh, well, okay. So it occurs at night. What is that telling you about? Okay, that could be your timing, remember? And then it lasts for 2 days, right? So if it lasts for 2 days, that's telling me what? Duration, right? So now I picked about, out of the HPI, how many elements did I pick up? I picked up the barking of the cough, which is the quality. I picked up when it occurs, because it occurs at night. That's going to be the timing. And then I've picked up how long it lasts. Okay, that's going to be my duration. So how many bullet points is that? How many things did I pull out? I pulled out 3. If I pulled out 3, we have 2 to choose from the HPI. It's either going to be brief or it's going to be extended. Being that we have selected 3 bullet points, your HPI is brief. You got to remember that. So you're going to, in your question, and I'm telling you, you'll maybe get 1 question like this out of the 10, but I like talking about it. I like explaining it. I like E&M. So I just want to go over it. So you have to remember that your HPI, because remember there was 3 things we needed to get for the HPI. I'm sorry, for the history before we can get the level. You have to remember your HPI. So jot down your HPI, and you said your HPI was brief. Right. All right. Review of systems. Okay, where do we go for our review of systems? Our review of systems are on page 7, right? And we already got the number to give you what level my review of systems is going to be. So let's see what's going on. So the patient has a runny nose. Uh-oh, sounds like respiratory. No ear pain. So whether they answer yes or no to a particular question for a body system, it's going to count, right? Because you said no doesn't mean we don't count it. I still asked about it. So yes or no's count, all right? So I said runny nose, that's respiratory. No ear pain. So that's going to be ears, nose, and throat. Oh, wait, my nose, I don't know why I said respiratory. So remember, they said no ear pain, runny nose. That still only counts as 1, right? And then they said they had what? A slight fever. That's constitutional. So the fever, weight loss, that goes on to constitutional. And then it says no complaints of chest pain. That's your respiratory, right? No complaints of chest pain. So how many do we have for your review of systems? You had 3. So what do you say 3 is? 3 is going to be, so your ROS is extended, right? Your your ROS is extended. Now what else do we have? We have the past, family, social history, right? Remember the categories. Okay, so let's look at that. They're talking about the patient. Patient is up to date on all immunizations. All right, I'm looking down here at past history. I'm looking for immunizations. Yep, that's there. That's a bullet point. That's one, right? And currently takes Zyrtec daily. Okay, well, that's about his current medications. That's still in past history. That's still in past history, right? No known allergies, because they ask about prior illnesses or allergies. That's still in past history. No known allergies to medication. So guess what? They asked 3 things, but they were only in one area, right? And so remember, what are your 2 levels for your past family social history? You're either going to have 1 or you're going to have complete. And for this particular scenario, although they asked 3 questions, it was only in one area, which was the past history. So for your PFSH, it's going to be pertinent, right? Let's see. All right, so that's what we have here. Now let's look at it. This is what we came up with. So we said our HPI was brief, so that's why they highlighted those 2, because those 2, we're trying to get 3 in a line. We're trying to get 3 in a line. All right, so we said our HPI was brief. We got that, right? And then we also said our review of systems was extended, which comes down here, which was 2 to 9. And then we decided that our past family social history was pertinent, right? So you have to have all 3. Because all 3 are not lined up, we can't choose detailed. Even though detailed seems to be the highest one, we need to have, if it can't meet, we have to drop back 1, right? So we're going to drop back because we can't get that extended to get it to detailed. All we can use is expanded problem focus. So guess what? You got your level of your history. So the level of your history, 1, 2, 3, is an expanded problem focus. Sometimes they'll just say EPF. So you got to remember the level of your history. So I jotted that down, right? So that's the level of our history here, expanded problem focus, because we have to drop back. They have to meet. They all have to meet. And I'm thinking this is I think we're doing this as an established patient. This patient is an established patient. All right, so now that was the hardest part, guys, the history, which I thought was kind of fun. And guess what? Most systems, most facilities, they have E&M calculators. So it's like you're just clicking bullet points all day. I can do that all day. I like that. That's not long, extensive surgery coding charts. This is like, okay, progress notes, right? Not 100 pages, maybe 2 pages. Anyway. All right, so remember we got the level of our history, and now we're moving on to exam. Exam's really quick, right? So exam, where are we going to find our exam? I said turn to page 9. Turn to page 9 for your exam components. And you'll see with the exam that it's talking about body areas. It may be body areas or organ systems. They'll count, right? Body areas or organ systems. So I'm on page 9 right now. I'm on page 9. And I'm looking at where it says determine the extent of the examination performed. You see that? Determine the extent of the examination performed. This is where you're getting your exam from. So you want to maybe write exam here or arrow right here, 2 arrows. It's where you get your exam from. So where it says, you'll see they're all listed down underneath comprehensive, the bullet points, you'll see head, neck, chest, abdomen. So there are your body areas, ending at each extremity. See that there? 1, 2, 3, 4, 5, 6, 7 of them. I'm missing one. I'll turn the page on page 10. That's where the rest are. Okay, that's where they end. So don't just think they're right there. But anyway, where it says problem focused on page 9, okay, where it says problem focused on page 9, I want you to write one body system, or you can just put one, because we're talking about body systems. Where it says problem focused, right, that's one body system. Where it says expanded problem focused, expanded problem focus, that's 2 to 7 body systems, 2 to 7. Okay. Where it says detailed, it's still 2 to 7, but they're going to spend extra time on one of those particular body systems. They're going to spend extra time in detail in one of those systems. Okay. And comprehensive is going to be 8 or more. 8 or more. So problem focus, 1. Expanded problem focus, 2 to 7. Detailed, 2 to 7 with 1 in detail. And then comprehensive is 8 or more. Okay, so that's the rest of the different organs and body systems. So of course, you're trying to read how many body systems when it's time for the exam part component of it, right? So this is just a summary of what you just wrote in your book. You have problem focus, 1 body area, expanded problem focus, 2 to 7, detailed, an extended examination of the affected body area, and related, but one is in detailed. Remember, it's an extended exam. The other one is a limited exam. And then comprehensive is 8 or more. 8 or more organ systems, okay, for comprehensive. So now we're on to the exam portion of the progress note or the encounter. Okay, so let's count what they got going on here. So they got constitutional. Is that over here? Where's constitutional? Constitutional is part of your review of systems, right? Yeah. And then, okay, so let's look at the body parts then. So they have perla, that's ear, nose, and throat, right? That's only going to count once. And it says, so you're thinking about your body areas. So when they say that's your temperature, perla, your nares are wet, that's going to be respiratory. Nose, I'm sorry. I love confusing those two. And your throat is going to be respiratory. All right. Those are on page 10. I'm just looking at those. So you got respiratory, you got the ears and the nose, that counts as 2. And then you have your skin. All right, so let's see what they have here. So you had at least 3 or 4, right, that you picked up. So that's going to give your exam. Let's see how easy that was. The exam, you're done with your exam. That's all you have to do for the exam component is just count those particular areas. So you could actually just count them here. Because you have 1, 4, and that still falls between your 2 to 7. All right. So your exam is expanded problem focused. Okay. Last step, make sure you wrote expanded problem focus down. You can't forget. Your last step is your medical decision making, which is on page 10. Your last step, I know it sounds like a lot, but you can see there's a process to do it. And once you get experience, you move a lot quicker. Okay, and certain conditions will equal certain levels of bullet points. But on page 10, This is where you're going to find your medical decision making. And on page 10, where it says determine the complexity of your medical decision making, right? It gives you what you're looking for, right? It has your 3 bullet points there, the number of possible diagnoses, the amount of complexity of the medical records, and the risk, how much complication is going to go into treating this patient. Where it says table 1 at the bottom, there's a couple of things I want you to do for me. Next to where it says minimal, I want you to write 1. Where it says limited, 2, multiple, 3, and extensive, 4. Okay, that's under the number of diagnosed management options. And to me, those numbers represent how many diagnoses they have. That's to me. This is how I use this chart, right? Skip where it says the amount of complexity and data to be reviewed. Go over to where it says risk of complications and or morbidity or mortality, right? So I use this as an example. Where it says minimal, I want you to put gargle, right? So here's what I mean by that. So you go in and you have a sore throat, right? Minimal treatment provider is going to say, go home, use some Listerine, gargle with some salt water. It's minimal to treat it, just sore throat, right? Low, you see the one next underneath it, low, I'm going to say over-the-counter drugs. When I say over-the-counter drugs, I'm talking Aleve, Tylenol, Bayer aspirin, that type thing, OTC, right? Where it says moderate, that's going to be more of like a prescription. Oh, hold on, let me prescribe you some penicillin here, right? That's moderate treatment when it has to be prescribed. And then high, we don't even have time for prescription. It's like it's time to take those tonsils out, right? So that's when surgery is going to be required. So where it says high, I want you to make sure you write surgery there. So this is just basically talking about what is on page 10. So make sure you read the bullet points there where it talks about to determine the complexity of medical decision making. Okay. And so you can see the types of decision making is that last column there on your page. Right? And it has straightforward, low complexity, moderate complexity, and high. Right? So basically, this is the same, that this slide that you're looking at is a mirror image of table 1 on page 10 in your CPT. So the medical decision making, remember we did look at this, this is the chart here. We looked at the chief complaint, HPI, review of systems, past family social history. We counted on the exam. And AMP stands for assessment and plan. Assessment and plan. Okay, so what did we end up with? This patient had croup, right? What did the provider tell him to do? Use a what? Cold air humidifier. Okay, so it wasn't really like, time for surgery. He said use a cold air humidifier. And I don't know if he would just have that sitting at home. So to me, it would be between low and moderate, right? So they said it's low. And you could have done it too by the diagnoses. Remember, there was one diagnosis, which would give you a straightforward medical decision making. See how we did that? Okay. And these are just other factors. We're going to go back to the little encounter in just a second. These are other contributing components. If that patient had any counseling, if they had to do any coordination of care. Okay. And if counseling, if more than 50% of the time was spent counseling, then we wouldn't even need to go through all of this. We would just look at the amount of time and code it. All right. But for this patient, okay, so they have this patient as being established. So if I looked at my reference page, right, back to page 1, and they said this is an established patient of the office. I'm going to look at page 1. I'm like, okay, office patient, they're established. What page do I go to? Page 12. So I'm going to be on page 12, right? And let's see what they said is going on with the history. They're established. Okay. History and exam really, history, when they're an established patient, they only have to meet 2 out of the 3 components. Remember, when they are established patient, they only have to meet 2 out of the 3 components. When they are a new patient, they have to meet all 3. If they can't meet all 3, you're going to drop back 1 to the lowest level. Okay, let's look at this. So this patient, remember we had our history that we jotted down way back when? And our history was expanded problem focus, right? And our exam was also expanded problem focus. And our decision making was straightforward. But remember, this is an established patient, so they only have to meet 2 out of the 3 key components, which the 2 of those components are over here. And if you go down to the level of visit, that should put you at a level 3. Okay. So again, category was office. Subcategory was that they were established patient. And if they're an established patient, they have to meet 2 out of the 3 components, right? So the 2 that they met were the history and the exam, and that made them arrive at a level 3. Okay. Some of the common modifiers, and we're going to do some questions, so no worries, and I'm going to open up the lines and we can just, just talk about how exciting this whole thing was. Some of the modifiers, common modifiers that go along with the E&M section. Modifier 24. Modifier 24, let's remember the big surgeries when they have those surgeries, it's in the global period. And if the patient goes back to the provider's office during that global period, that it's basically covered. It's not covered if it's related to that patient's surgery, right? Well, modifier 24 is like, yeah, I know I had surgery, but I'm coming into the office today because I got a sore throat, right? So modifier 24 is saying, I know it's the global period, but I'm coming to see my doctor for something else, not what what was in reference to the surgery. That's what modifier 24 means. Unrelated evaluation and management service by the same physician during a postoperative period. Okay. Modifier 25 is also a E&M. So remember that it's an E&M modifier. Modifier 25 is appended to E&M codes. And basically what it's saying is, okay, I come in for a physical, a yearly physical. That's an E&M code, right? But then the doctor, he sees a wart in my neck and decides to remove it in the office. Right. So the wart removal is going to be separately identifiable than the yearly physical. So I'm going to put a modifier 25, or I'm going to append a modifier 25 onto that E&M code. And then I'm going to also code for the removal of my wart, which is going to come from the integumentary section. And then modifier 32, we spoke about that, right? Like child support, court mandated, insurance company mandated. They're saying, the paying agency is saying, hey, I need you to go get this test. That's when you would use modifier 32. Modifier 57, be aware, they will try and trick you with this one. Modifier 57 is appended on to a E&M code, not a surgery code. Modifier 57 means decision for surgery. Usually that surgery is going to occur within 24 hours, right? So you're not going to put a modifier 57 on a surgery code. It's going to go on a code that begins 99 because usually you're at the provider's office and he's like, you got to get those tonsils out right away, right? And so he would append on his office visit for that day, modifier 57, so that the insurance company has some type of pre-warning that I'm going in to have surgery within the next 24 hours and they won't deny it right? That's what modifier 57 is for. They won't deny that office visit. So again, we covered the components, the key components on how to establish your levels for the history, the exam, and the medical decision making. But of course, there's a lot of guidelines there, and they become more comfortable with use. Right? We're just exposing you to E&M. So the type of questions that you're going to see are what I want to cover. But before I do that, I just want to open up the lines to see if anybody needs clarification on anything before I continue to blab my mouth. So the lines are open. Any questions for me? Is it informative?
This is Rochelle.
Hi.
It's hi, good afternoon, evening. I
Hi.
guess I'm just I guess I'm following you,
Hmm.
but I guess I'm just confused
Yeah.
with
And that's why I want to do at least 10 to 15 questions so you can see how easy this is going to be.
yeah, it's just the components that's what's really confusing when to use a 2 out of 3.
Okay.
Yeah.
And
So
that's what these reminders are for, to make sure, that's what these examples are for, because it sounded like it was so much, but once we start to go through this, you're going to be like, oh, okay, got it. Right. So anybody else have any questions? So I want to make sure, Rochelle, that you understand before we hang up. These are the type of questions that you're going to see, what we're about to go over.
I
Yeah,
have one
this.
question.
Oh, I'm sorry. Go ahead.
Go ahead, Michelle. I thought you was finished. Go ahead.
Hmm.
No,
oh,
that
I'm
this
done.
was.
Go for it, guys. Rochelle, were you done with your statement?
Yes, I am. Thank you.
Yep, no problem. And I hope, let me know, because we're going to go through these one by one. And,
Okay.
at the end, if you're like, hey, I still think I need a little bit more on the E&M, then we can do that. And remember, next week, guys, you have your mock final. So you will, and the mock final is 150 questions. So of course you won't be dialing in. I will be sending the mock final out to you, right? And this is a true evaluation of where you are right now, right? Because this is going to be covering everything we've covered up until this point. And it's important that you take it honestly and really try and time yourself, because what I would like to do, because we're going to have, if next week is your mock final, that's still October, right? So then we'll have like November 3rd and maybe another November date before the boot camp. Right. So we'll maybe be able to squeeze in another 2 sessions. That's what I did with the previous class. And the reason I'm saying that is because those additional 2 sessions are going to be kind of more informal. And so I'd like to know where you feel your weak areas are, so we can, make use of that time and focus on those areas. All right. Just so you know. So you will be getting that mock final. I'm also going to be emailing you the E&M homework, but I definitely have to make sure I feel comfortable with you guys and that you feel comfortable with this, because it seems a lot what I just spoke about. Because imagine if you had to do that for every question. That alone would take 5 hours and 40 minutes, right? And the AAPC knows that, and so for the most part, it's already kind of calculated for you. And I'll tell you what I mean. Like if you're looking at number 12 right now, we're going to go through all of them, but you can see
Um,
they already say 3 HPI, 2 ROS.
can you blow it up a little bit, Janine? Can you make it
Ooh, I
bigger?
don't know if I can get this bigger. Let me try.
Well, you know what? It might. Wait a minute. It might be me.
Did you expand your screen? Because it should be pretty.
Yeah, you're right. It was me. I didn't
Okay,
expand
because I was
mine.
like, God, wait. Let
No,
me.
you're right.
Wait. Let me go back.
I,
Yeah,
I can see it now.
you can see it. Okay,
But
perfect.
I
Yeah,
just wanted to say I agree with Rochelle. This
yeah.
is Andrina.
Yes.
Um, it was a little all over the place for me, so I really don't know. I
Okay.
don't know what to do.
Let's do this. Let's
But
start.
but but
I want to
Maybe
make
with the
you feel,
scenarios,
yes, absolutely, for
maybe with the
sure.
scenarios, I would kind of be able to, guide a little bit faster through it.
What?
I mean, not guide faster, but you kind of understand a little bit more.
Okay, let's look at some of them, right? So you got to have your books in front of you. All right, so number 10,
Okay.
once I say mandated, you're like, okay, I'm done with number 10, right? So number 10, and I'm going to need you guys to make sure you're participating. This is the only way that I could know. Number 10, I want to make sure that you guys are putting your answers in the chat box. And during the boot camp, I will have a little cheat sheet that you can draw in your book to kind of help you, because I have it in mine. Like that little grid. We saw those little grids in the presentation, especially that last one for the leveling. But let's just talk through some of these. So number 10, I see Cherie's already got our answer in there. Number 10, what modifier is used to report E&M by a mandated court order? Yes, everybody's like modifier 32, right? And you may see a question like that, and thank God it doesn't take 2 minutes to answer it, because we need to move on. So we're moving on to number 11. This is where I really want to start to focus. Okay, let me go back. Now listen what we're doing here. So 32-year-old patient, she sees Dr. Smith for what? It's already telling you a consult, right?
Mm-hmm.
So remember, my whole thing is you need to know where you are, right? Page 1 through 3 gives you all your locations. And we're looking for, she's going in for a consult at the request of her primary care physician. It's not like you had to try and figure it out. Remember, you need to know what they're going in for, right? So if I'm looking for consultations, right, I turn to page 2 in my reference pages. Consultations, it tells you consultations. It says go to page 19. But now, remember the subcategory. I know it's a consultation, but what type? Is it inpatient or outpatient? Okay. If they say primary care physician, guess where they are? They're not in the hospital, right? Because it would say inpatient or, facility. So the key here is his PCP. So that means his consult is going to be provided in the office. So if I go to consult on page 2 and I go to office, it's going to tell me that I need to go to page 19. So let's go there. Well, page 19 is where it starts, so you can flip to page to 20. When you flip to page 20, what's the first 4 numbers that you see on that page? This is what I'm trying to tell you. You have to learn how to categorize this test, right? How to break down this E&M. If I see that 9924 is for my consult codes, I know I can get rid of A and B. Do you see what we're doing? We're already narrowing it down to 50%. The only thing you don't know is that last number. And we're not going to, guess what? You're not going to have to do all those bullet points that I just showed you. I needed to show you because that's the manual way and you need to know how to do it. But the way the AAPC has constructed this exam, they've done most of the work for you. They've done most of the work for you. So remember the 3 key components of what? The history, the exam, and the medical decision making. Right now, the only 2 selections I have for number 11 for my answer is going to be 99243 and 99342. Right? So what I'm looking for now that I know what my first 4 numbers are, I need to know what that level is. Okay. So let's look at it. So yeah, they came in, they have allergies, they've been using Claritin, Alivert. See, this is just describing stuff, right? Haven't been feeling any better. The symptoms continue to worsen. Look, this is what I'm looking for. When I'm reading E&M questions, what I'm looking for are those 3 key components. I want to know what the history is. I don't care about all that other scenario stuff. I'm looking to see what the history is, what the exam is, and what the medical decision making is. Right here it says Dr. Smith performed what type of history? An expanded problem history, expanded problem focused history. That's what it says, expanded problem focus. So guess what? I'm looking at 99243 and I'm looking at 99242. And I'm like, okay, which one has an expanded problem focus? 99242, right? So you put a little check mark. So you're like, okay, I'm looking at 99242. It's looking like a contender, right? And then, so that's for the, it said expanded problem focus for history and exam. Do you see that? It said expanded problem focus, history, and exam. So guess what? Two of those are already in 99242. Do you see what I'm saying? Because in order for me to use 99243, it would need to be saying detailed. It's not saying detailed. It's saying expanded problem focus, history, and exam. And then he discusses with the patient options on allergy management, right? What's the medical decision making, or the MDM? They say the MDM is straightforward. So in your box, in the chat box, please, what would my answer be? Do you see we're looking for the three key components? They're right. This is easier than surgery coding. We just got to practice it, and we're going to practice it tonight. You're going to get this. E&M is not going to be the reason. So don't try to put it on E&M. Forget about what you heard and who you heard it from. Okay, it's self-explanatory. Don't make it more than what it is, especially for this exam. Okay, so the correct answer for number 11, is C, and I see everybody that put an answer in the chat box is correct. See, I told you. That was just number 11. Let's look at number 12. Okay, Dr. Hauser sees Mrs. Jones in Clinic 8 for sudden loss of consciousness. So that's going to be a diagnosis code, right? While watching the Olympic torch go by. He is a new provider to the neurology department. Okay, so they talk about Dr. Drake Rinaldi, a prominent member of the neurology faculty at the university, saw Mrs. Jones last month. So he saw her last month, right? So is she going to be new or established?
Established.
Right. Look, go back to page 1. Turn back to page 1. I get chills. I get all excited and silly and stuff. All right. Go back to page 1. We already know she's established and she's going to the clinic. So that's the doctor's office, right? So so office visit, we're on page 1. We're at the bottom half. We're looking at evaluation and management. I just asked you, is she new or established? You said she's established because he saw her last month. So what page do we go to for established patients?
12.
12. Okay, established patients, what's the first 4 numbers? 9921 at least, right? For established patients, 9921. We don't know what the 5th digit is, but we know the first 4 are 9921. What does that tell me? That means I can get rid of C and D. Why are you even looking at it? It's not a contender, right? And now we may have to use our little bullet points, but it's okay because our bullet points have taught us how to get that level, right? So let's see what's going on. So we already know it's either going to be A or B for our answer for number 12, right? So let's see what's going on here. Well, first of all, I can look at 5 and I know my 5s need to be high, right? Complex, complete, that type of thing. But let's keep reading. So let's see. So Mrs. Jones came in last month. Dr. Hauser performs a history, including, look, we got to go keep your finger on page 7. Page 6. How many HPI elements? She had 3 HPI elements. That makes her HPI brief. Remember? Real quick, we already got it calculated. She had 2 review assistants. My review assistants are on page 7. If she had 2 review assistants, that makes her review assistant what? Extended, right? And then what type of exam did they have? You remember your exam comes from page 9. and they said they had a detailed exam. It's already giving you the type of exam, a detailed exam, right? So your exam was detailed. All right. So just remember, you had a brief HPI, extended review of systems. All right. So let's look at 992. You have two options here. You have 99214 and 99215 for number 12. Right. So let's look. Those are established patients. We already know what page to go to. So I'm looking at 14 and I'm looking at 15. First of all, in order to use a level 5, what key components do you have to have? You have to have a comprehensive history. That didn't happen, right? Because first of all, her HPI was brief and she only had 2 reviews of systems. So how can she have a comprehensive history, right? Although she has a medical decision making of high complexity, which would put her at a level 5, remember you have to have 2 out of those 3 components. 2 out of those 3 components, which means she would have had to have had either a comprehensive history or a comprehensive exam in order to bill that 99215. So because they don't have those 2 components, remember I said you have to drop back. So we're dropping back to 99214, right? So for number 12, the answer should be A as in apple. Can we get that? Do we understand? Even if you're looking at the 3 key components in 99215, you would have to have, everything would have had to have been at a high level or complete to use a 99215. Once you start to see that HPI is only 3 elements and they only looked at 2 body systems, there's no way that could be a comprehensive examination. Is it making sense?
Yes, Janine, this
Yes.
ain't Trina. A quick question.
Yes.
I think the light bulb just kind of coming in just a little bit.
Okay.
Turn it on.
We're
So the
starting on the
fifth
low
digit-
dim light. We're just dimming
Yeah.
it. We're turning the knob. Okay.
We're
I'll take
turning
that.
it a little bit.
I will take that. Go ahead.
Okay. Okay, so the 4th digit is actually the level, correct?
Well,
I'm sorry, the fifth digit.
yes, the 5th digit is going to be your level. Your 5th digit has to do with those 3 key components, those black bullet points.
Okay.
Yeah,
So
that's what's really putting you there. The first 4 are basically just putting you in the location.
Meaning as far as the 4th digit, it let us know whether or not the patient is established or a new patient.
Perfect. Yes.
Okay. Now, in this scenario, even though you broke it down and to find exactly which CPT code, couldn't we just did the ICD-10 code?
Yeah, but it's about E&M.
I know. Okay, I was just saying. I'm just trying to save some time,
you know
but I was just wondering.
But you
I'm
know
just saying,
what? It's easier to actually find your first 4 digits than look up that I-10 code. Do you know how many pages you got to go through to flip through
That's true.
R55 and R40?
Yes, that's true.
If we're going to talk about but if we're going to talk about a tiebreaker, like let's say I didn't know what was going on number 12.
But see,
let's just you would have just did the
Okay.
I-10.
After I would have found out the patient was new or established. Now that's what I would have done because I'm more.
But they try to trick you. Don't let them trick you because look at this. If you went straight for your, let's say you knew it was R55.
Okay.
It's still going to be like, do you know whether that patient's new or established? You're still going to have to look for it because
Well, that's what I was.
Yeah, you're still going to have to
Okay.
look. I think
No.
Go ahead. I'm sorry.
I'm sorry. I get what you're saying. No, I was just saying, and just only in this case. That's the only thing. I still want to know how to break it down and code it, just like you just showed us.
Yeah.
I was just wondering.
Now, when it all fails and you're not sure, absolutely, will you be looking up that I-10 code? Right.
Okay.
For sure.
Because I know that we're going to be pressed for time. I know that, and I think that's one of my biggest scare is going to be the time.
And that's why you got to kind of look at it and kind of chop
Mm-hmm.
it down. And now you've given yourself 50-50.
Okay.
And that's what I'm saying. It's actually not bad at all if you use these that reference page, page 1, page 2. It's actually not
Mm-hmm.
bad at all because, like I said, if you can find the location, you're 4 numbers in your code already.
Okay.
You understand what
Okay.
I mean?
I do.
And you'll see when I go through it. So number 12 is A. Number 13, guys. Number 13. This is just FYI. But when tissue glue is used to close a wound, involving the epidermis layer, how is it reported? And remember, that's like a simple closure. So number 13 is A. I didn't want to spend time on that question. Number 14, here we go again. Now remember, E&M, I'm looking at my page 1. I got page 1 through 3 ready. Fingers are ready. Okay, so number 14, Dr. Jones documents Mrs. Smith's condition has improved during her 3rd visit. Where is she? She's in the hospital. And he said her 3rd visit to her hospital room. So she's not being admitted. She's already there, right? This is her 3rd visit. So what does that mean? So that means she's in the hospital. So that's hospital inpatient, right? Turn to page 2, right? That goes under subsequent hospital care. Remember? She's already there. This is the 3rd visit to her hospital room. So I'm already like, okay, it tells me subsequent hospital visits. What page do I need to go to? It's even giving me the code range. It's even giving me the code range right on page 2. But it's telling me go to page 17. I'm like, okay, I'll go to page 17. And on page 17, subsequent hospital care, first thing I'm looking for, what are my first 4 numbers? That's the first thing I want to know with my E&M. Okay. First 4 numbers for subsequent hospital care, 9923, right? 9923. So we already know we can get rid of A because 99221 is actually a hospital admission. It's a hospital admission. So yeah, now we're down to B, C, and D. And you got to use your brains here when you're reading. Okay, so she's in a hospital room. So here's what the doctor says. When I went into the room, I found her sitting up in bed, watching TV, and eating breakfast, right? Now I want to know, remember the 3 key components, because now we have left B, C, and D. But what we're looking for is a problem-focused exam. Okay, look now, we only got 3 to choose from, and the key components, we're looking for a problem-focused exam. Which one has a problem-focused exam? Is it level 1, level 2, or level 3? Level 1. We already see that. Look, it says problem-focused exam and low medical decision making. Okay. Out of all those 3 codes to choose from, which one has low medical decision making and a problem-focused exam? The answer's in the box. Answers in the box. We are E&M coding. Right. Correct. So number 14, correct answer is B as in boy. How we feeling so far? Do you get what I'm doing a little bit here? Just a little bit?
Yeah.
Okay,
Yeah.
good. All right,
Yes.
let's do some more. Let's do some more. All right. Number 16, and I am going to send you guys this attachment. I am going to send you this, and this is exactly how you're going to see them on your exam. This is exactly how you're going to see it on your exam. So number 16, a pediatrician is asked to be in the room during delivery of a baby at risk for complications. So anytime I see time in my question, you're going to highlight it. Anytime you see a time in the E&M question, you're going to highlight it. Okay. The baby is born. Okay. So first of all, 45 minutes, right? We've highlighted that, put a circle around it, whatever you do to get excited. The baby is born and is completely healthy, not requiring the services of the pediatrician. What CPT code is or are reported by the pediatrician? Okay. So, I mean, I'm looking at these numbers. How do you even know what to look for? What would the heading be? You know, what would the heading be? So what is it, 99360? Anybody know what heading you would go under for this? Anyone? Anyone? The correct answer would be C. That's for standby services. Remember? The baby's high risk, so the pediatrician is being asked to be in the room. He's being asked to be in the room. So those are standby services. Okay. He's asked to be in the room for 45 minutes because the pediatrician is asked to be in the room during the delivery of the baby. They didn't say he was delivering the baby. They just said they asked him to be in there and he was there for 45 minutes. That's considered standby services. And for number 16, that would be 99360 because 99360 is for 30 minutes. Okay, it's for 30 minutes. And it's not a complete additional 30 minutes, so we can't do times 2. Can't do times 2. Any questions on that? All right, 99360. All right, number 17. Here's a you can tell when I start to see dates, this is maybe going to be what? An observation when you see dates, right? Back to page 1. I'm looking for observation. I need to know where it is. Where's the hospital observation? Is it a hospital observation? That's where observations are held. So let's see, what are we looking for? So we want to know, first of all, I'm going to need to know when it's observation, whether they came in and out the same day or whether they came in and left on a different date, right? Look at my number 17. When did they come in? They came in on January 21st. When did they leave? They left on January 22nd, right? So how many codes am I going to need? You're going to need 2 codes. Do you remember? Come in one day, leave the other day. Look at A, B, C, and D. I said you're going to need 2 codes, right? What are those 2 codes going to be? Or what answer is it for number 17? Number 17. This is observation in one day, out the next day. And you will see one of these. Yay. I see an answer. Anybody else? Monica, Cherie, perfect. Anybody else? Anybody else? Number 17. We're doing good tonight. Perfect. I'll take 4 or 5 answers. All right. So the correct answer for number 17 is D as in David. Remember, I can go to observation, right? Because we have different dates in one day, out the next day. You can go straight to page 14. It tells you to go to page 14. I've already wrote on the top of my page different days on that page, right? And we know that when they came in, that would be 99218. And when they left, that would be 99217. So for number 17, the correct answer is D as in David. Yep. Number 18, here we go. This is what your question, you should be able to fly through these, guys. Number 18, the attending physician at the hospital. How long? I'm highlighting time in my question. Spent 25 minutes with the patient in the morning, right? 25 minutes. Remember, it doesn't have to be all consecutive. And then spent another 15 minutes in the afternoon. How long is that? 40 minutes? Examining the patient, writing discharge orders and giving discharge instructions to the patient. What CPT code should be reported? Now we're talking about hospital discharge. Go back to page 1. Okay, that's hospital inpatient services. And then you turn to page 2 because it's a subcategory. It's going to tell you hospital discharge services. You need to go to page 18. I'm at page 18. I said, how long was it? I did my 25 plus 15. That's 40 minutes, right? 99238 tells me that it's 30 minutes or less, and 99239 tells me that it's more than 30 minutes. Easy as pie. Please place your answers in the chat box for number 18. Number 18 is B as in boy. Correct. Told ya. Number 19. The EMS bought a 31-year-old motor vehicle accident. Where? Where's my location? Who? Emergency room. Page 1. I didn't even finish reading the question because I need to know where I need to be before I read. Okay, so where are we going? To the ER? So I'm looking at page 1. And then turn to page 2. It tells me emergency department services. Turn to page 22. You see what we're doing? We can do this quick, guys. You can do this quick. So I'm in the emergency room department. I know for number 19, okay, so they have all 3 levels here. They have levels 2 all the way through 5. So now we need to read. Keyword in this thing, right? Look at it. If you know the answer for 19, you could throw it in the chat box, but she's 31. She's gone to the emergency room department. After what? A comprehensive history, a comprehensive exam, and a medical decision-making of high complexity. What else do you need to look for? Why even look at the other codes? That's as high as it gets, right? So number 19, and the provider determines the patient has multiple internal injuries and needs surgery right away. That could not be a level 2 visit. If I was a provider, I'd be like, you got to go. Do you know how much work I did last night? Right. So once you see comprehensive history, comprehensive exam, medical decision-making, high complexity, your answer is D as in David for number 19. Number 19. And then we'll just throw one more in there, which is number 20. And then we can talk for a little bit about this. Number 20. So a physician visits Mrs. Smith where? In Mr. Smith in his home monthly. Today, so look, page 1, right? Page 1. Turn it, look for page 2. Where did they say? Home services. Okay, let's see. Are they new? He says today, a physician visits Mr. Smith in his home monthly. So they didn't say for the first time. They said monthly. So that means he is a established patient for home services. Where do we need to go? Oop, tells me right there. I love this book. I love it. It tells me to go to page 31, right? Tells me to go to 31 because they're established. Now I need to see what's going on when he's seeing her at home, what kind of visits, so I know to look for my key components. So they say today he performs what? A problem-focused history. Okay, what else? An expanded problem focus examination. Whoop, that puts me at another level, right? Now I'm at 6. Expanded problem focus examination, and a medical decision making of low complexity. Medical decision making of low complexity. Answers in the chat box, please. Remember, they got to get 2 out of the 3, and then you can capture that 2 out of the 3. So for number 20, yep, that looks like your answers. Number 20 in the chat box, please. So number 20 would be B as in boy. Adriana, are you there? I want to know what you guys think about this since we just did a few examples. Are you like, was that it? Are you like, is it more to it than that?
I do need to ask one question, Janine.
Sure, sure.
This is Sandra. On the add-on codes we went over on 32 and 33, pages 32 and 33.
Okay.
Are those add-on codes go to what?
They go with E&M codes. So for
Okay.
example, yeah,
Well,
like this is all E&M. These are prolonged
Okay.
E&M. Like you could have came in for your physical and then
Uh-huh.
he wants to counsel you maybe about diabetes that you just found out you had, and he spends like an additional 40 minutes talking to you about that. So there's one for psychotherapy, and there's so the 99354 that's on page 32 is more like psych services, right?
Mm-hmm.
Prolonged services. And then on page 33, where you have that 99358, 99359, those, do you see that? Those are for like, well, those are without direct patient contact. And your 5.4 through 5.7 is just like the time you spend talking about a particular condition or educating that patient about that condition. And it has to be, and you'll know because it will say the provider spent additional time. And you'll also know on your ABCD because you'll see the code there. But what the trigger for you is going to be is, let me see how long the visit was. Because if it's under 30 minutes, you can't even use the code.
Okay. So this is for all EM codes? These
Yeah, yeah.
add-on?
These add-on codes can be
Okay.
used, and it
Okay.
will tell
That's
you,
all.
don't forget that underneath your CPT in the parentheses, it will tell you what range of codes you can use it with.
Okay. 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 Thank you.
Yep, no problem.